So we are good to go. So we are live now.
Yeah, thank you. A very good afternoon, everyone, and welcome to No Thrombosis Symposium, today's program. And before starting this program, I just want to inform everyone is that the No Thrombosis program is most engaging scientific platform from any pharma company, has been awarded by Healthcare Excellence Award 2021. So with this, today's we are going to start with our No Thrombosis Symposium. And today we are very glad that with us our post director Dr. Dr. R. Kasliwal sir is with us. Dr. Kasliwal sir has he's an also adjunct professor of cardiology. He is the chairman of Division of Clinical and Preventive Cardiology and Community Outreach Program Medanta, the Medicity. Sir has in distinguished cardiology career spanning more than 4 decades after receiving medical education and training from the finest institutes. He is mentor of Diplomat National Board of Cardiology Fellow and also fellowship program in clinical and preventive and non-invasive cardiology. He is also a mentors physicians of India and abroad in field of echocardiography preventive cardiology. Amongst the more than 2,275 national international awards, he also received the prestigious Dr. B.C. Roy National Award for the year 2004 by Bharat Ratna Dr. A.P.J. Abdul Kalam sir. He was the President of India. Subsequently, he has received 2 more awards from the late Dr. Abdul Kalam. He has 375 scientific research papers to his credit, and he is the founder of editor-in-chief of the journal Clinical and Preventive Cardiology, and also applied echocardiography in coronary artery disease. So he is Dr. Kasliwal sir father, Dr. Colonel R.M. Kasliwal sir was personal physician to Netaji Subhash Chandra Bose, and he was the principal of SMS Medical College, Jaipur. He was a reversed physician and teacher. The father and son wrote a book that is The Impact of Netaji and INA on India's Independence. He is the current president of South Asia Society of Atherosclerosis and Thrombosis. He is the past president of Indian Academy of Echocardiography, among others. Also established community outreach program to provide free cardiac care to community at grassroots level, which has successfully completed 2 decades. So from behalf of Emcure, I welcome to Dr. R. Kasliwal sir for today's No Thrombosis Symposium. So with this, I will hand over the session to Dr. Kasliwal sir.
Thank you.
And take the session forward. Thank you, sir.
Thank you. So dear colleagues, it's my pleasure and honor truly to be here this afternoon. So good afternoon. It is my pleasure and honor to chair this important session today titled No Thrombosis, sponsored by Emcure Pharmaceuticals. The topics are clinical, clearly important, and commonly encountered. I am thankful to Emcure for hosting the symposium and bringing such top-notch specialists for the interaction today afternoon. The topics that we will cover today are non-valvular AF, role of NOACs by Dr. Saxena, PAD management, new dimensions, Dr. Tapesh Sahu. Each speaker has ample time of 20 to 25 minutes. And please send your questions for an animated Q&A session at the end of both the talks. On this note, ladies and gentlemen, I thank all of you who have tuned in this important session, because I believe, and I repeat, these topics are clinical, clearly important, and commonly encountered. My first speaker today is Dr. Anil Saxena. Dr. Anil and I have known each other since 1990, and he's an extremely intelligent gentleman, and he's the executive director of cardiac pacing and electrophysiology at the Escorts Heart Institute and Research Center, where I had the privilege to be there for about 20 years. Dr. Saxena is a very humble person, very humane person, and has been the president of the Indian Heart Rhythm Society, which is a big honor. and continues to be actively interacting with PACE, the journal PACE, a premier journal for electrophysiology. He was investigator and co-investigator in many top-notch clinical trials like Optimize, Rocket AF, Validate, and so on. But you know, the real worth of a person is different. Your humility, your humbleness, and your grasp of the subject, that is very important. And therefore, we have a real gem today who will talk to us on non-valvular AF, the role of NOACs. Ladies and gentlemen, I present Dr. Anil Saxena.
Yeah. Good afternoon, sir. Good afternoon, everybody. Thank you for a very generous introduction. It's indeed a pleasure to be with you in this session. You have been one of my very close mentors, and it has been a pleasure working with you for a long time. So my task today, friends, is to talk about the role of NOACs in valvular atrial fibrillation. And over next 15-20 minutes, I'll talk about this particular topic. I hope my slides are visible.
Yes,
so we
they are.
know that atrial fibrillation is a very common arrhythmia that we encounter in our clinical practice. In fact, up to 1/3 of all arrhythmias that we see in the office practice are atrial fibrillation. And it's very easy to recognize, and we know that it's a arrhythmia of old age. So as the population becomes aging, like it's happening in our country as well, but in the Western world, the population is very old, so the incidence of atrial fibrillation keeps on rising. The lifetime risk for atrial fibrillation in European ancestry has been assessed to about 1 in 3 individuals. And it is slightly more common in males. Now, as far as the clinical problems are concerned, there was a time when AF was just considered an appendage to diagnosis. But now we know that atrial fibrillation is not something very benign. It can be associated with higher mortality. There is a high risk of stroke with it. About 20-30% of all ischemic strokes and up to 10% of cryptogenic strokes are because of atrial fibrillation. It can contribute to heart failure in a significant number of patients, increases hospitalizations, and impairs the quality of life. And in many patients, it leads to dementia or cognitive decline. Now, when it comes to management, the guidelines for last many years, they focus on a very important aspect, that is stroke prevention, and which has now come at the forefront, in fact, because that is something where patient cannot tell us that, doctor, please prevent my stroke, because they have no knowledge. They will tell us about the symptom, they can tell us about palpitations, breathlessness, so that they will obviously force us to control. But stroke prevention is something that we have to think ourselves. So whenever we see a patient with atrial fibrillation, we should always think of preventing thrombotic complications, because we know that in atrial fibrillation, there is a stasis of blood in the left atrium, particularly in the appendage, and which can form a clot, which can dislodge and cause systemic embolism or brain embolism. The other things I will not discuss today, like lifestyle modification, upstream treatment, rate and rhythm control, and all that, because today's talk is mainly focused on stroke prevention. In fact, there is another concept now, it's called ABC pathway for atrial fibrillation, which also mentions anticoagulation or avoiding stroke as the first important thing. And initially, we used to think about high-risk patients in whom we would start anticoagulation treatment, but now the concept is to seek out low-risk patients, because it is now recognized that most of the patients actually require anticoagulation, and we have to just identify the low-risk patients who have a Church-Basque score of 0 or sometimes 1, especially in females. So we have to recognize and not give anticoagulation. Otherwise, we must give anticoagulation to majority of patients with atrial fibrillation to prevent thrombotic complications. So there is a slight, one of the very important things is that the first thing that we do is to see whether our patient with atrial fibrillation has a mechanical heart valve or moderate to severe mitral stenosis. If any of these things are present, then we should just continue with there's no other choice available to us. We just have to give vitamin K antagonists, that's warfarin or acetrom, as they are available in India, and not think about NOACs in that situation, because these patients, they have not been tested in most trials. Only one trial was done, which was negative, realigned trial. I will come to that subsequently. So they are contraindicated. If these two things are not present, then we look at the CHA2DS2-VASc score, and if the score is 2 or more, then we give anticoagulation. And as of now, OAC is preferred over warfarin. It's a class 1 indication to give in preference to warfarin or vitamin K antagonists. Now, coming specifically to the topic of today, that is valve disease. As I said earlier, if patient has severe or moderate mitral stenosis or mechanical heart valve, then we don't give NOACs. But there are so many other valve diseases which may be present in patients with atrial fibrillation. Some may be incidental, some may be the cause of atrial fibrillation. And in fact, it's a very common thing to have more than 100 million people worldwide have valvular heart disease. In our country, we have rheumatic heart disease still prevalent in many sections of society. And as the population is aging, so degenerative valve disease is also quite common. So valve disease is present in a significant number of patients. In fact, IHRS, Indian Heart Rhythm Society, did a registry and we from 24 centers across India, and we found 48% incidence of rheumatic atrial fibrillation, which is quite high. But many government centers were involved. The percentage in private hospitals was less, which was quite expected. But other trials also, which had Indian arms like the PANAM, Realize AF, Rely, IHRS-AF, of course, have discussed Pinnacle, and so many. All of them have shown about 40 to 45 to 48% incidence of valvular heart disease in patients with mitral with atrial fibrillation. Now, another aspect that I want to discuss is that these terms are now discouraged by the latest guidelines. Particularly, the lone atrial fibrillation is something which is discouraged now. But more important from today's point of view is that this definition of valvular and non-valvular is discouraged by the latest recommendations from the European Society of Cardiology, because they feel that while patients with moderate or severe mitral stenosis or mechanical valve, they were not included in the trials and they were called valvular atrial fibrillation, but there are so many other native heart valve disease and patients with bioprosthetic valve or valve repair surgeries and all. Everybody should not be clubbed together. So this term needs to be redefined. So this is a slide that I have prepared where we can classify our patients into three main categories. One is the patients as they were defined in the trials, the valvular AF, that is moderate to severe mitral stenosis or mechanical heart valve. This is one category of patients where NOACs are certainly not to be considered. The second category is AF with coexisting valve disease, which could be mild mitral stenosis, it could be aortic valve disease, tricuspid valve disease, pulmonary valve disease, or patients with bioprosthetic valves or valve surgery, repair surgery. So this is a separate category of patients, and they can be further divided into rheumatic etiology and non-rheumatic etiology. And lastly, we have all other patients who don't have any valve disease. So there the choice is very clear that we must give NOACs in preference to warfarin. And in the first category, in the MS and mechanical heart valve, there is no confusion. We should not give NOACs, just focus on vitamin K antagonists. It is the middle category that we are going to talk today, which is patients who have atrial fibrillation requiring anticoagulation and they have coexisting valve disease. Which one to choose, NOACs or warfarin? Vitamin K antagonists. So we should begin with this premise, and whatever we discuss, the subsequent evidences in different categories of patients, this thing should hold true as of today, that NOACs are contraindicated in patients with prosthetic mechanical valve, and they should not be recommended for patients who have moderate to severe mitral stenosis. That holds true as of today. So about the dosage selection, I think we can skip that. That is not the topic of today. So let us come to NOACs in atrial fibrillation and valve disease. Now, we know about 4 pivotal trials: the Rely trial with dabigatran, Rocketeer with rivaroxaban, Aristotle with apixaban, and edoxaban trials. So all these trials, they were done to define the role of NOACs in stroke prevention in patients with atrial fibrillation. And a significant number of them had patients who had valvular heart disease, 22% with the RELY, 14% ROCKET-AF, 26% Aristotle, and 13% with the ENGAGE-AF trial. So all these patients, they had the trials, they had significant number of patients who had valvular heart disease. In fact, there were thousands of patients of this category. And when a meta-analysis was done, and they found that the overall efficacy and safety of NOACs is similar in AF patients, whether they have valve disease or they don't have valve disease. So they behave in a very similar manner. So we should not separate out patients for a separate strategy. There was another meta-analysis which included one more trial, the DAVA pilot trial, and they also included patients who had native valve disease, bioprosthetic valves, and valve repair surgery. And they also found that the behavior of patients with respect to NOAC is similar for stroke and systemic embolism, whether they have valve disease or they don't have, they behave in the same way. For intracranial bleeding, again, there is significant reduction compared to warfarin with NOACs. And as far as the bleeding complications are concerned, they are more or less similar. So both these meta-analyses concluded that NOACs can be safely given to patients who have valve disease, other than the two things that we talked about, severe mitral, moderate severe mitral stenosis or mechanical heart valve. Now, important point here is that these trials, although they showed that NOACs are okay, but they were not randomized. They were not randomized for this particular thing. They were randomized trials, but not for this. So a trial has been conducted, which is called RIVER trial, which is a randomized trial on patients with atrial fibrillation and bioprosthetic mitral valve. And this was mainly necessitated because in ROCKET-AF trial, there were no bioprosthetic valve patients, which was done on rivaroxaban. So it was necessary to see the efficacy of NOACs in this particular category of patients. So what they did was they took 1,005 patients from 49 sites in Brazil, and they were randomized to receive either rivaroxaban or warfarin. And it was basically a non-inferiority trial. So rivaroxaban was given in the usual dose, 20 milligram daily, and 15 milligram for creatinine clearance, 30 to 49 ml per minute. And it was analyzed on intention to treat basis after a follow-up of 12 months. And the primary endpoints were death, major cardiovascular events, or major bleeding. And the secondary endpoints were each of these individual components, and of course, bleeding events, etc., were analyzed. So what they found at the end of 12 months was that the event-free survival time was 7.4 days longer with the rivaroxaban compared to warfarin. So it was better in that sense. And the p-value for non-inferiority was less than 0.001. So it was very significant for non-inferiority. Now they looked at analysis in all three manners, that is intention to treat, per protocol, and as treated. And they found that if you see per protocol and as treated, it's actually superior to warfarin. Rivaroxaban was superior to warfarin. But if you analyze only on intention to treat, then it is non-inferior, but it lacked superiority. So, but the point which they concluded was that it is as good as warfarin or maybe better. And these are the secondary efficacy endpoints, and we can see that almost all are similar with warfarin as well as rivaroxaban, except stroke, which is much less with the rivaroxaban. So it was significantly less. P-value is less than 0.05. As far as the bleeding complications are concerned, there were no intracranial bleeding, there were no fatal bleedings with rivaroxaban, and otherwise it was quite similar to warfarin. And this again is the time from the mitral valve implantation, less than 3 months. The RMST difference was significant. So they found that the conclusion was that in patients with atrial fibrillation and a bioprosthetic mitral valve, rivaroxaban is non-inferior to warfarin as compared to with respect to mean time free from death, major cardiovascular events, or major bleeding. But they also mentioned that we cannot extrapolate these findings to prosthetic aortic valve because only bioprosthetic mitral valve patients were included in this particular study. Now, I will discuss some other evidence with respect to use of NOACs in valve disease, which exists today but has not been taken notice of the guideline writing committees. This is a very recent trial which was done in patients with mitral stenosis, where patients with native mitral valve stenosis were given DOAC and compared to warfarin. So it was not a randomized trial, but 1,900 patients received DOAC and about over 5,000 patients received warfarin. And they found that as far as ischemic stroke and systemic embolism is concerned, DOACs was superior. And for intracranial hemorrhage, it was more or less similar, but all-cause death was less with DOACs in patients with mitral stenosis also. So the conclusions were that in patients with atrial fibrillation accompanied with mitral stenosis, the use is promising and hypothesis generating for further studies. This was basically a off-label use in mitral stenosis in patients who just could not take DOAC, warfarin for whatever reason. There are patients who cannot monitor. There are patients who would not take warfarin. So in them with prior consent, it was given. But this was not a randomized trial. So the conclusions are mainly hypothesis generating for further trials. Now, as far as the mechanical heart valve is concerned, we all know that the dabigatran trial on the mechanical prosthesis was stopped halfway through because of excessive bleeding complications, excessive thrombotic complications, and some mortality also. That's called realign trial. So after that, it became contraindicated that one should not use DOACs in mechanical valve patients. But obviously, this cannot continue forever. So the efforts will be made for use of DOACs in mechanical valve also. And this is one of the studies which has been done, REVA study, where 44 patients were randomized to receive either rivaroxaban 15 milligram twice daily or warfarin. And they found the data was quite encouraging. They found it as it was a proof of concept study. And the authors have suggested that we should do a larger trial with similar design. It would not be unreasonable because they found that the thrombotic and bleeding events were similar to warfarin in patients who had mechanical heart valve. So coming lastly to the choice of anticoagulant. So it is quite evident that for patients who don't have valve disease, that is on extreme right, there is no doubt we should prefer NOACs over warfarin. That's a class 1 indication. And for patients who have moderate or severe mitral stenosis, we must prefer VKA only. And for patients who have atrial fibrillation coexisting valve disease, we can use NOACs. However, many people believe that the patient has rheumatic etiology. We should still prefer VKA till we have more proof, especially in rheumatic patients. There's a trial going on, which is called Invictus trial, where All India Institute is one of the participants, where they are including rheumatic patients, and that will probably provide us with the conclusive evidence. But till then, many experts feel that VK should still be preferred, but non-rheumatic, certainly we should use NOACs in this particular population. So friends, the key messages are that atrial fibrillation has increased the incidence of thromboembolic complications that we know for a long time. And the long-term anticoagulation is something that we desire in all these patients to prevent stroke. Warfarin is approved for mechanical prosthetic heart valve or moderate to severe mitral stenosis. But other patients with valve disease, including those with bioprosthetic valve, can be given NOACs. So I think I will stop here. Thank you so much for listening.
Sir, Kasliwal sir, you are on mute, sir.
Yeah, I'm fine.
Yeah.
So thank you very much, Anil. This was, I'm sure there'll be a lot of questions because oral anticoagulants and NOACs, people are definitely wanting to give something where the people don't have to rush for an INR every day. Anyway, that we will come to. But ladies and gentlemen, now it's my privilege to introduce the second speaker, Dr. Tapish Sahu, who's a vascular surgeon, and he has 2 decades of experience in vascular surgery. And he was with us at Vedanta for a period of time, and I had a great time interacting with him. He's has done a lot of endovascular work with us, and he does that with an aplomb. Apart from that, as I said, it's not what is written in the CVs which is important, but it's our attitude and our hands-on skills which are important, and that's where Dr. Tapish Sahu comes over everyone else. So, Dr. Tapish, it's my privilege that you please take over, and Dr. Tapish Sahu will speak on, obviously, pad management, and will take us to new dimensions in pad management. Ladies and gentlemen, Dr. Tapish Sahu.
Thank you, Kasliwal sir, for a very generous introduction. And right from the cardiology, from the coronary field, we are going onto the similar application of this medication of dual pathway inhibition in the peripheral domain, in the peripheral arterial domain, which is, I think, equally important. And this is a new paradigm. In the past 3 to 4 years, we have been talking on this, and gradually the evidence is also accumulating in terms of the practical experience of all the clinicians. So regarding the peripheral PAD management, what are the new dimensions? Although these are not any more new, but still newer than what was existing in the past 10 to 15 years. So I am Dr. Tapish, and we'll be talking about the epidemiological aspects of PAD. How underrated is this PAD? What is the current management, and what are the guidelines for further modifications in our management? What are the new dimensions? What is the dual pathway inhibition we are talking about? As Dr. Saxena said, had also talked about various trials and various Indian trials underway, and how things have changed over a period of years. And all of the clinicians here have a hands-on experience with this drug in all dosages, be it 20 mg, 10 mg, 2.5 mg BD, all have practical experiences. And let's just talk about the epidemiology followed by treatment part. So what is the prevalence of PAD? PAD is the third leading cause of atherosclerosis, morbidity following CAD and stroke. CAD obviously is more fatal, but PAD combined with CAD or not combined, presenting only as PAD, wherein the coronaries are not identified, may be more devastating sometimes. The PAD prevalence ranges from 5% among people in the age of 40 to 44, and it increases as the age increases up to 12% of people between 70 to 74. And as the age increases, the bleeding risk also increases. So that is also one of the caveats in the treatment that has to be kept in mind. There are an estimated 238 million people living with PAD worldwide. That is the reported incidence, but actual incidence will be much, much more than this. This is just the tip of the iceberg. And despite its prevalence and clinical importance, PAD has been historically underappreciated, because this is one thing which people feel may not be fatal as the coronary events will be. The maximum that can happen is patient will be amputated, the limb loss will be there, but they do not realize that ultimate is the life loss that happens even if they are suffering from PAD for a long time. In the past several years, a body of evidence has indicated that these perceptions are incorrect, and all epidemiological studies have stated that ultimately PAD will lead to some kind of coronary complications, which will lead to the life loss also. That's why in today's era, we are talking about MALE and MACE as a combined outcome rather than only the limb events. The cardiac events are also being talked about in the PAD. And that's why we are talking today afternoon, we are here to discuss about the optimal management of these patients. Many patients with PAD are not receiving evidence-based therapies. They are receiving experience-based therapies rather than what exists in the whole world. There is enough literature to say what proper medication should be used in these kind of patients, in those patients who are being managed medically, in those patients who have undergone some kind of intervention. What should be the follow-up medication? This is a very important burning question that everybody asks as of date. The atherosclerosis may involve all beds. So it is a polyvascular disease. The underlying cause may be diabetes, blood hypertension, smoking, hyperlipidemia, and also age-related atherosclerosis may be there. PAD may involve many territories, including the carotids, the upper limbs, the mesenteries, the renal arteries, lower extremities, which is the acronym will be using the LEAD, the lower extremity artery disease, and the presentations are corresponding to the bed involved. So this is what I was saying, that if we look at this graph, we see that these are three lines, these three plots that you see here. So PAD with MI or stroke has a 14.9% cumulative incidence, while 7.6% in MI or stroke and no PAD. So the inference from this, what I'm trying to say is that PAD recently gained attention in the context of polyvascular disease, and PAD without MI or stroke had a higher risk of major adverse cardiovascular events than MI or stroke without PAD. What I mean by this is, I'll just clarify in simple language, that patients with peripheral arterial disease who do not have an identified coronary bed involvement, they may have a higher risk of major adverse cardiovascular events because they may not be on optimal medical therapy than the patients who have had some warning signs of a coronary involvement, and they are in touch with their own cardiologists who are managing them properly. So that is why that has been already recognized, and they may have a lesser MI or stroke if some warning signs have happened initially, because they are on optimal medical therapy. PAD is largely underappreciated and under-recognized, so that's why they may not be on proper optimal therapy, and they are at risk of having more cardiovascular events than patients who are already in touch with a cardiologist. So if we talk about the income, the effect of high income, low income, and middle income strata on these peripheral arterial disease, the prevalence of PAD among men has typically been higher than women in high income countries like the developed countries, while in the low income group countries, the women are experiencing PAD up to 2 times more, and this is also increasing in the high income countries because of the lifestyle changes that are coming off late, by more tobacco use, by more stress related hypertensive related atherosclerosis. The PAD prevalence for both men and women significantly increases with age, that has already been talked about, and as the age increases, be it a high income, low income, or a middle income country, the PAD will increase. And of all the patients with PAD, roughly 11% progress to chronic limb-threatening ischemia. So previously we were talking about CLI, now we talk about CLTI, which is the new terminology as per the GBG guidelines, which is the most severe form of PAD, and patients stand to lose their limb if they are turned into the terminology of CLTI. So men are slightly more affected than women, and overall, if we talk, the men have more incidence in all income group countries, ranging from 3.11 per 1,000 patients versus women, which is 2 per 1,000 patients. So clearly, overall, the men are more affected because of the lifestyle of date. So the treatment algorithm, this was regarding the problem statement, talking about the treatment algorithm. If the patient has a clinically diagnosed peripheral arterial disease, the first thing to do, which we tend to forget, we tend to jump onto only the medicines. We tend to forget talking about the lifestyle modification, which is the first step in all studies, in all publications, in all kind of management, the behavioral counseling, the interventions, including smoking cessation, weight management, exercise therapy in their lifestyle, control of sugars, control of lipids, control of blood pressure by appropriate medications by their clinicians. Then comes the antiplatelet management and the controversies about the oral anticoagulation that we'll just highlight. So glucose management is very important. Only giving the antiplatelets and the HbA1c remaining 10 or 12 is not the target that should be there. Always the HbA1c should be hovering around 7. That is the target that should be there. The lipid management has to be very aggressive, and lipid profile has to be done. And based on that, the statins have to be given in these patients. And looking at the myopathy or other side effects, health also the clinician should be looking into. The blood pressure management should be, the target should be the systolic between 135 to 145 and diastolic between 60 to 90 should be the target. The antiplatelet management, the aspirin or clopidogrel, that is single antiplatelet, the single antiplatelet monotherapy should be given in all symptomatic PAD patients. Now the myth is that the blood flow is getting increased in blocked arteries or atherosclerotic arteries. It is not for that. The antiplatelets are to reduce the coronary, the cardiac mortality or the morbidity. If the patient is having a concomitant coronary artery disease that has been diagnosed, then long-term dual antiplatelets may be considered if low bleeding risk. Otherwise, the single antiplatelet agents may be instituted for a long time to reduce the cardiac manifestation. If the PAD diagnosis is the only thing that is there, then continue antiplatelet monotherapy. Regarding oral anticoagulation, there have been various trials regarding giving low dose of oral anticoagulants or therapeutic dose of oral anticoagulants, and the bleeding risk has to be balanced with the ischemic risk. So if the ischemic risk is more than the bleeding risk, some have advocated addition of low dose rivaroxaban to low dose aspirin monotherapy, and that is the crux of the COMPASS trial, that it reduces the MALE and the MACE if the bleeding risk is low. If the bleeding risk is high, the oral anticoagulant should be avoided. But let me specify here that oral anticoagulants are not used for anticoagulation in this dose. It is the synergistic effect with aspirin in low doses, which is giving you a dual pathway inhibition rather than an anticoagulant, which is generally in the doses of 10 mg or 20 mg. So this is the antiplatelet effect that is being utilized in dual pathway inhibition. So these are the American guidelines. Again, the same thing. We're talking about monotherapy, dual antiplatelet therapy, and oral anticoagulation. So this is that monotherapy should be with aspirin or clopidogrel, class 1A evidence, and dual antiplatelet aspirin plus clopidogrel, that is recommended only in patients, in PAD patient undergoing revascularization. If a stent has been placed, then dual antiplatelet should be given. Otherwise, monotherapy is fine. Oral anticoagulation is gaining traction these days because of the Voyager trial, which say that post revascularization, the low dose can be added. Otherwise, if there is no intervention, then the suggested PAD use is only, as per American guidelines, only 3A. While in patient with symptomatic PAD, it is now 2A evidence, which because of the COMPASS and the Voyager trial, it is gaining better level of evidence in medical management. Similar are the European guidelines. So the VKAs are now going down because VKAs, even in low dose, are not being used because of this novel therapy wherein the bleeding risk has been less. So overall, the European Society of Cardiology guidelines for PAD in 2017 had said that antithrombotic therapy, the lower extremity arterial disease in patients requiring long-term oral anticoagulants, symptomatic or asymptomatic incidentally detected disease, or patient undergoing surgery should be receiving oral anticoagulant OSE monotherapy, that is class 1 recommendation. The implication here is that if they have undergone any percutaneous intervention and the bleeding risk is low, then either aspirin or clopidogrel. Right now, the recommendation is that for 1 month, the dual therapy should continue, and after 1 month, it is whatever is the clinician is comfortable with to continue with a monotherapy. And the bleeding risk, if it is high, then the monotherapy should be given. That is the class 2A recommendation. So evidence underlying medical management on patients with PAD, we're talking about the various trials in cholesterol reduction, in antiplatelet therapy, anticoagulation, the peripheral vasodilators, the exercise therapy, and smoking cessation. So if we talk about statins, it is class 1A evidence. The PCSK inhibitors, class 2A. Aspirin, again 1A. Similar is with clopidogrel. Warfarin is lower than this. Rivaroxaban, which is we are focusing on as the COMPASS trial, which came in 2017. This is combined with low dose aspirin reduces male and MACE and should be used in preference to aspirin alone. So dual pathway inhibition is recommended, and the clinical benefits with preventive treatment, that the aspirin with low dose rivaroxaban, that has a 28% net clinical benefit. The hazard ratio is reduced. There is 46% reduction of major adverse limb events, including major amputation. So this is clearly indicated in patients with preventive or post-intervention treatment, adding the low-dose rivaroxaban to low-dose aspirin. So this is a very important picture that whatever is the treatment, patient is having coronary artery disease, peripheral arterial disease, both polyvascular disease, or even after dual antiplatelet therapy, all crossroads lead to one intersection, that is dual pathway inhibition. All converge after some time into maintaining the therapy. So the maintenance will be by low dose 2.5 BD combined with aspirin. That is, individuals with these should be considered for dual pathway inhibition. So the European Society for Vascular Medicine, even this is not surgery, this is the vascular medicine, the evidence-based medicine, say that based on the COMPASS trial, this should be considered without a high risk of bleeding. The class of recommendation is 2A in these class of patients. So to summarize all the RCTs, the COMPASS trial, the COMPASS lead, the lower extremity sub-analysis, or the Voyager PAD, they say that in patients on only medical management, the major bleeding was lesser, the net clinical benefit is better, so this should be given. In post-intervention patient, by TIMI definition, the major bleeding was significantly statistically not significant. The p-value was 0.07. The intracranial or fatal bleed, the hazard ratio was falling not in favor of the aspirin alone group. So all in all, to say that in both the groups, in COMPASS trial or Voyager trial, the net clinical benefit of dual pathway inhibition is more than the safety outcomes. That is, the bleeding risk was weighed lesser than the efficacy outcomes, which were weighed more. So what is the patient profile? Just to tell regarding all those who are attending, that COMPASS patient should, what is the class of patient who should be instituted on this therapy? So patients of PAD who have undergone revascularization, who have had a previous limb or foot amputation, history of intermittent claudication, and one or more of the following: ABI less than 0.9 or significant PAD more than 50% documented by angiogram or by Doppler, or previous carotid revascularization, which is a very important group, or asymptomatic carotid artery stenosis more than 50%, who are amenable to medical management as diagnosed by Doppler or angiogram. A patient with a coronary artery disease with a low ABI less than 0.9. So these are the class of patients who should be instituted on dual pathway inhibition. So if we talk about the male or MACE, the lowest graph that you see here is the rivaroxaban plus aspirin arm. The forest plot, if we see, the best effect is found in the carotid artery disease medical management, and overall COMPASS falls towards the rivaroxaban and ASA, which is better than ASA alone. So no arm falls towards ASA. So it's a clear-cut benefit in reducing the male and MACE, which is having a 31% relative risk reduction. And Voyager PAD, which is a completely different presentation, which we'll be doing later on. This is just to summarize that Voyager was for post-intervention patient, and it concluded that among patients with lower extremity PAD undergoing revas, rivaroxaban aspirin was associated with a reduction in major adverse limb and cardiovascular events as compared to placebo or aspirin alone. So the acute limb events, acute coronary events were lesser in patients having these dual pathway inhibition. So to summarize, that PAD is a devastating disease. Despite the multitude of medical treatment options available, PAD is chronically undertreated. Among individuals with lower extremity PAD, the development of male is associated with a poor prognosis. Antiplatelet therapy remains cornerstone of PAD management, with clopidogrel decreasing limb events. Newer to this paradigm is the addition of rivaroxaban in low doses, which is basically targeting the atheroembolism, the reduction of atheroembolism. And latest evidence suggests that 2.5 daily with aspirin significantly lower the MALE and MACE, and this combination should be considered as an important therapy for patients with PAD. Thank you for your attention.
Thank you, gentlemen. I think you've set the ball rolling and we've got very, very good information from all of you. Before we take the chat box questions, let me ask just one question each to the speakers. Dr. Anil, you mentioned about the REVA study, which is a proof of concept study in mechanical valves and the use of NOACs. Any more headway since the study was released?
Sir, there is one more study which is again done in about 70-80 patients, which has come and shows similar results, but there's no big randomized trial which is, to my knowledge, underway. But
this will be a great help to patients.
Definitely, because and many people believe that there is no reason why they should not be of benefit. There is a criticism of the Realign study, which was done on dabigatran, that most patients were randomized too early, they thought. And because the main bleeding complications were pericardial bleeding. There were no other bleeding except pericardial. So they thought that patients were randomized too early, within 7 days. And the dose was also very high in many patients, up to 300 milligram twice a day. So it's just a matter
Dr. Anil, tell me,
yes, sir.
Are you now convinced that if there's AFib and a bioprosthetic valve, mitral valve in the mitral position,
yes,
you would be confident in giving them NOACs?
Yes, sir. Because there were patients in the pivotal studies also, except for Rocket AF study. But then on rivaroxaban, there is this river trial, which is sufficiently large, 1,000 patients randomized to NOAC versus warfarin. So the guidelines also recommend that for all other patients, other than moderate or severe mitral stenosis or mechanical heart valve, we can use NOAC.
So mild mitral stenosis, atrial fibrillation,
yes,
we can go ahead and use NOACs. Dr. Sahu, before they open up for the Q&A, it's very fantastic, the way you put up that PAD is a poor cousin of CAD, but it isn't. Actually, PAD can cause more devastation or equal devastation than CAD. So that point that you have brought forward is really very good. Why? Because routinely we have been doing brachiofemoral ultrasonography in all patients going for, and we find that carotids are 30-40% blocked, and so you brought it up very well, and you therefore introduced the concept of DPI, which I personally have been following, and I think this is a very good concept. To your mind, do you think that DPI is still underutilized in our country?
Definitely, sir. The concept is still not very prevalent and very being utilized properly, because the drug which is rivaroxaban is still considered an anticoagulant, and the people fear the bleeding complications of this drug more. They have been using aspirin or clopidogrel for a long time, and they're still any change takes time to be instituted. The second was regarding the cost involved for long-term therapy, but that has come down significantly. The thing is that the clinicians have to be properly educated and properly told about the use of this drug in the lower dosages where it is causing dual pathway inhibition rather than causing anticoagulation. The name rivaroxaban is synonymous with blood getting thinned out, and people fear that in peripheral areas, if they land up with bleeding, they may say that, okay, he's just a claudicant, he has just undergone this thing. Why give him these strong drugs? These are the words of certain clinicians. But if they try and understand that this in 2.5 will not cause that much of bleeding based on the scientific evidence, then the proper utilization will happen. And as CAD and PAD, that CAD is more seriously recognized, and that's why Dr. Kasliwal and Dr. Saxena are more famous than us. But then the PAD is also gaining traction, because that is the reflection, that is the mirror reflection of what's going to happen with them if they are not adequately medically managed, and they may land up into bigger complications of cardiovascular events.
Tapish, as a matter of fact, one of our first papers on early detection of coronary artery disease was actually on carotid ultrasonography, and I still swear by it. And therefore, in all my post-bypass, post-angioplasty patients, whatever they may do, but I will definitely have a look at their carotids and femoral arteries. And I know that opportune time when, if it is truly a polyvascular disease, I will put them on DPI in the long term. So I know that window. And there is enough literature which goes wide. So these things, and number two, we also use a lot of ankle brachial ABIs. And ABI has helped us in getting many vascular Dopplers done in the lower extremities. And then once we find atherosclerotic disease, we do start them on DPIs on a long term, and they do very well.
And that's why all your preventive health packages are having the IMT and Doppler and ABI in all your patients who are undergoing this coronary profile. And that's why you have instituted that. That's a great step, sir.
Yeah. So thank you very much. So Dr. Ravi Kasur, if you have any questions, please let the speakers know, let me know, and then we can open it up for everyone else.
So that's it, sir. I think we have many questions in chat box. I think there are, some relevant questions we can pick and we can discuss.
So please go ahead. You just name one for Dr. Saxena and Dr. Sahu, so that we have a lively discussion.
Yes, definitely. So the first questions I'm going to take is that, Aniki, what are your views on prophylactic anticoagulation for secondary prevention for stroke? So this question is asked by Dr. Anand B from Cochin, sir. So Anil, sir, any?
Yeah, so secondary prevention means that the patient has already had a stroke. So his CHADS-VASc becomes 2, irrespective of any other risk factor being present. So these patients definitely need anticoagulation. Anybody with atrial fibrillation having a stroke requires long-term anticoagulation as a secondary prevention measure.
Thank you, sir. Thank you. And one more question. I think next questions will take. Is NOAC a good alternative to warfarin if long-term prescribing needed? So this is a question asked by Dr. Praveen from Mumbai.
Yes, it's a very good long-term alternative for several reasons. One is that the efficacy is similar or better. Secondly, the convenience, the safety is better, definitely. And the convenience is there. There is less requirement of following food and medicine restrictions. The interactions are very less. So there are several advantages of giving NOAC as compared to vitamin K antagonists, provided we rule out those two contraindications like the moderate or severe mitral stenosis and mechanical prosthesis.
Okay, Dr. Kosar, I have your chat box here. So there's one question from Dr. Praveen Palekar from Mumbai. Is NOAC a good alternative to warfarin if long-term prescribing is required?
Yes, sir.
It should be.
Absolutely, sir.
Okay. Then Dr. Jabir from Bangalore asks a question. What, according to you, is the optimal antithrombotic regimen for secondary prevention? I'm sure he wants to know secondary prevention of coronary artery disease. What do you think?
So I don't think that's a question relevant to this session, sir.
Yeah, that's true. So this question you've already answered. Can we use rivaroxaban in bioprosthetic valve in the mitral position from Dr. Sachin from Pune?
Yes, sir. Yes, sir. It is both the guidelines also permit, and the RIVER trial is very clear on this, that it can be used. It's the last trial, randomized trial, good results.
But only in the mitral position right now?
Yes, sir.
Okay. Since both of you are here right now, let me also ask one thing, that we also have to emphasize the fact, Doctors Anil and Dr. Tapish, about the drug-drug interactions which happen with rivaroxaban, for example, and fluconazole or erythromycin and ritonavir. What are your views? That what caution should we take? It's nice to prescribe, but in these days of polytherapy as well, what would you say we should take care of?
So I think antivirals and antifungals are the main drug interactions. And other than this, rivaroxaban also interacts with food, and the food actually increases the bioavailability. So it should preferably be given with food. And the second thing is there may be some interaction with the drugs like verapamil, which should be given at least with 2-3 hours difference. But main interaction is with antivirals and antifungals.
Okay. So Dr. Tapish, there is a question for you. Can vascular dose plus aspirin is approved to use in PAD management by Dr. Bipin from Delhi?
Yes, it is approved.
Okay.
And by all guidelines, be it Indian, European, US, all since 2017 have included this as the level 2A and now 1B evidence that this should be added in all medical management of PAD, in medical management of the carotid artery disease, and in the further prevention of male and mace after any revascularization has happened. And whatever is the therapy that you are using for the first 1 month, after that for continuation therapy, this is safe and this should be used. There are enough guidelines and has been accepted as the first line.
I think, Dr. Kesar, these are the questions that we had, and I don't want to take the questions which are not relevant to our topics. If you want to say, if the speakers would like to say one last word, then we are well in time to go ahead with more work.
The only thing is that regarding, apart from drug-drug interaction, the comorbidities, the renal dysfunction, the hepatic dysfunction has to be kept in mind for these drugs, that the EGFR has to be seen while instituting these drugs, and hepatic dysfunction also you should know, and all the drugs that may cause concomitant hepatic dysfunction has to be kept in mind rather than only drug-drug interaction, and that is very important for failure or for causing bleeding risk in these patients.
Dr. Anil, one last word from you.
Oh, sir, thank you so much, sir. It's been a pleasure being with you and presenting in front of you. Thank you so much, sir.
Thank you so much. Thank you, Dr. Kos. Thank you very much.
Thank you,
Dr. Saud.
Thank you, sir. Thank you so much. Thank you, sir. It was really a pleasure meeting everyone. And, this is really a truly successful program because, more than, 1,300 registration has been conducted and almost more than 1,400 doctors has been, logged in for this session. And we can see there are more number of questions are coming for specifically for both the session, and very insightful presentation by Dr. Anil Saxena and Dr. Tapish also, and the hosted by our Dr. R.R. Kasliwal, sir. Thank you, sir. From behalf of Emcure, I want to say thank you so much to all of you, sir. Just before closing, we will show one video, sir. With your permission, we'll show 1 minute video. And
Sure, of course.
Yeah, thank you, sir. Thank you.
Do you know which Indian pharma company has consistently launched innovative first in India products? Presenting Emcure Pharmaceuticals. With over 500 scientists, we are pioneers in chirality. We have been making a healthy difference to countless families. With cardiology at our heart, we have strived to give you better products always. Chiral products are complex to develop. They are difficult to manufacture, but their benefits make a difference. A difference for your patients, for you. We are proud to launch our latest chiral development, Exafib, our indigenously developed rivaroxaban. Developed in-house, manufactured at our state-of-the-art facility at Jammu. This is a WHO GMP certified facility. We conduct quality checks to ensure only the best is delivered. Exafib complements our chiral cardio portfolio. Exafib, committed to make a difference in anticoagulation therapy for your patients.
Exafib, we have completed 1 year, and consistently 1 year we are number one brand
Do you
in
know?
generic brands, and this is all because of all the support has been because of all the support of all our doctors. So thank you, sir. Thank you so much, Dr. Anil Saxena, sir, and Dr. Takvi Shahu, sir, and as well as Aran Kasiwal, sir, for a wonderful session today, sir. Thank you, sir. Thank you so much, and goodbye, sir.